Good morning, everyone. My name is Eve Lossman, and on behalf of the University of Michigan Injury Prevention Center team and our colleagues at MDHHS, I want to welcome you to the fourth in a series of discussions related to the opioid epidemic. Today, we're going to focus on medications for opiate use disorder and acute pain management for patients who are currently on MOUD. We have about 90 minutes and we've built in time for Q&A, so please do ask questions and we'll address them at the end of this discussion. We are very pleased to have a panel of fantastic experts to share their knowledge with us today. Jill, next slide. I'd like to introduce you to Eliza Hutchinson, who also spoke at our first session. She is an assistant professor in the Department of Family Medicine at the University of Michigan. She is also the medical director of addiction services at Packard Health. Nick Rademacher is an adjunct assistant clinical professor at Michigan State University College of Human Medicine. He is also an emergency physician through Trinity Health Grand Rapids. And I'm Eve Lossman. I'm your moderator. I am an emergency physician at University of Michigan, and I am faculty in the University of Michigan Injury Prevention Center. None of us have any disclosures to make today. Next slide, Jill. So we have a very brief poll that we're going to put up right now. It should be popping up on your screens. If you can take a quick moment to answer these two questions, we would appreciate it. All right, I counted to 10, so I think we're ready to move on. Jill, next slide. So as we have spoken during our previous discussions, providers can make a huge difference when it comes to bending the curve of overdoses and overdose deaths in the opioid epidemic. We can make important decisions regarding prescribing opioids. That's kind of preventing the problem where it often starts. We can share in the education of patients, our communities, and our policymakers. We can help those with opiate use disorder to find treatment and enter recovery by prescribing medications for opiate use disorder and by creating a healing environment that is free of stigma. Last but not least, we can provide naloxone to patients who are at risk for overdose, and we can educate them regarding harm reduction. Next slide. As we have discussed during previous sessions, and as you will see today, we believe strongly that a holistic approach to harm reduction and to education and to policymaking is really critical. We want to be patient-centered in the care that we deliver in order to optimize patient outcomes. Next slide. There is a lot of work to do in addressing the opioid epidemic. Today, we're going to focus on one aspect, namely medications for opiate use disorder, but we are also addressing in this series of discussion numerous other topics. Some we've already addressed and some we will be addressing in future sessions, and a brief list is noted here. Next slide. This is our agenda for today. Please remember that to receive CME credits for attending this event, you do need to complete the evaluation that will be emailed to you once we are done today. So we are going to briefly discuss addiction and introduce MOUD. We're going to talk about MOUD in the ED as well as in the clinic. We're going to talk briefly about acute pain management, and then we're going to share some tools and resources and then do a Q&A. This session is being recorded, and we will make the slides available to anybody who wants them. There are wonderful resources available through open access channels, and we'll make sure that everybody who wants to learn about them does so. Next slide. So without further ado, I'd like to introduce our first speaker. Eliza Hutchinson is going to start our conversation with a brief review of addiction and an introduction to MOUD. Eliza, please take it away.
All right, thanks, Eve. Nice to be with everybody today. So before we get started more on kind of what we can do as clinicians and advocates, just kind of taking a step back again to review really what is addiction and sort of also importantly what addiction is not. What we now understand, as probably most of you are aware, is that addiction is very much a treatable, chronic, relapsing brain disease, and really involves complex interactions among brain circuitry, genetics, the environment, lived experiences. And historically, we really have not understood addiction to be that way, sort of as a society and as a healthcare community. Previously, it was very much sort of thought of as a moral failing or poor decision-making on someone's part. So we've really evolved our thinking, but we'll talk a little bit more in a few moments about sort of the legacy of that prior understanding. And really important for us to all know is that prevention and treatment approaches for addiction really are generally as successful as for other chronic diseases. So there is a lot of work to be done, but there is a lot of hope and a lot that we all can do who are here today. Just thinking a little bit more about the way opioid use disorder grows in a person. This chart can just kind of help us think about, when someone initially begins using opioids, right, that little space in the middle is sort of people feeling physiologically normal. And when they first start using, right, they sort of experience euphoria, and then they return. And then as the opioids come out of their system, they return to feeling normal, right? And that pattern continues for a while, where it's just that enjoyable euphoria with a return to normal in between. However, with chronic use, what we see is sort of that physiologic dependence occur, right? People get tolerance, and then when they aren't using, they do develop withdrawal symptoms. And so really what we see is that when people use, they no longer achieve any of that euphoria feeling, and really they have to use simply to feel normal. And over time, they need to use more and more in terms of potency, more frequently, in order to continue to feel normal. We are also trying to understand, right, how do we figure out who is going to experience addiction and who is not? And we have a lot that we understand and a lot that we still don't understand about how to predict this. But generally kind of thinking about our biopsychosocial model, many biological factors involved, right? So certainly age and gender, we're understanding more and more about how genetics play a role. People's initial physiologic reaction to a substance plays a role as well, right? So, patients might come in and say, if they're someone who has developed an opioid use disorder, often they can recount that, the first time they used an opioid, they felt tremendous relief, a sense of well-being. And then there are some people who will come in, or perhaps some of you have had this experience where, one experience using an opioid and you feel terribly ill, you never want to touch one again. So certainly that initial physiologic reaction can really influence people's tendency to develop an addiction. And then sort of thinking on the psychological front, right, this is sort of going back to all the adverse childhood experiences that get talked about so much now, and they really are formative for folks and influence, their mental health, their emotional health. And then, a lot of folks' beliefs and expectations also around substances do matter. From a sociological standpoint, we know, of course, that connection, social support, interpersonal relationships make a tremendous difference in both in recovery, but also just in the tendency to develop an addiction to begin with. Certainly socioeconomic status and socioeconomic struggles can increase the vulnerability to development of an addiction. So when we are thinking clinically about whether or not somebody has an addiction, We can sort of do this in part with Gestalt, right? With these, what we call the 4Cs on the right. So thinking about someone experiencing cravings to use, really loss of control of their use, right? So trying to cut back, but not able to do so. That compulsive use, which really goes along with sort of using despite consequences, right? Like people are able to recognize that there are negative consequences either to their health, to their social circumstances, to their relationships, but still are unable to cut back and continue to use in that compulsive fashion. And sometimes your patients, of course, will show up and this is quite clear. There are other times where, truly going through this diagnostic criteria from DSM-5 can be helpful to determine whether you really think somebody has an addiction. Really important for that DSM diagnosis is, there has to be some evidence of a physiologic change, going back to that chart that I showed, right, where people have developed that physiologic dependence, which is really evidenced by tolerance and withdrawal symptoms. And then some evidence of loss of control of use, and then using despite consequences. So although, we now understand addiction to be a chronic brain disease, there certainly is a long legacy of understanding it as a moral failing. And that really still manifests today as stigma. And we see this, certainly in society at large, but also within the healthcare space, even as our thinking evolves. Stigma really can be defined as a mark of disgrace associated with a particular circumstance or quality of a person that causes strong feelings of disapproval from most people in society. And again, this really goes back to that perception that, a person's situation or, in this case, their addiction is very much in their control. It's their fault. It is a result of their poor decision making. And then, of course, we see stigma become actual discrimination as soon as it causes a negative action, right? And sometimes those can be small, micro, or sometimes they can be much larger and more visible. And why does this matter, of course, in the clinical setting and when we're thinking about treating patients with addiction is, patients will stay away from treatment because of stigmatizing experiences in the healthcare system. Discourages folks from pursuing their recovery as people have this internalized stigma, which becomes tremendous shame that actually will cause people to kind of pull away from the healthier activities that help them sustain recovery. And then also, patients with addiction, because they have had challenging experiences in the healthcare system, may or may not feel comfortable being open with medical providers about their health issues in general, or specifically about issues that relate to their substances. So the good news is that, as healthcare providers, we can absolutely change this to some extent. This is in the sphere of our control. And part of it is, again, just being aware of biases regarding patients with addiction. And these are quotes from, providers over time or, things that may go through our head. Even those of us who work in the field, right? We have all sort of grown up and marinated in these kinds of thoughts. So being aware that we have them, I don't have time for this. These patients are more complex. They're more complicated. I don't want them in my clinical setting. Why are people being rude or irritable? The assumption that people won't ever get better and there isn't really a treatment, or sort of like, why is this worth my time? So just, being really aware of those biases. We can, provide education to others. We can help open the dialogue around the disease, and we can certainly change our language as well, which can have a really tremendous impact. And so, this is just a chart, and probably people have seen various versions of this chart in many places. But these are helpful. I think about this topic all the time, and I keep this posted in my office as well, just to remind myself, because these words can still slip out. So kind of words to avoid on the left and then words to use on the right. And this really aligns with sort of all, person first language that we are trying to use in all of the healthcare profession. And over on the right is just, again, sort of a study that showed the real impact of stigma on substance use disorders, specifically as it relates to use of language. So in this, there were these different scenarios, and in one of the scenarios, someone was referred to as a substance abuser, and the other was the person was referred to as someone with a substance use disorder. And so this, the results really showed that when the term substance abuser was used, the providers were more likely to, or they were less likely have patients actually benefiting from treatment. Providers were more likely to see the person as being socially threatening, and people were more likely to be blamed about their substance use difficulties. So really some significant outcomes simply from using that different language. So as healthcare providers also, these are tools that we can use to educate ourselves or use sort of in the advocacy space, and there are wonderful infographics on a lot of these websites. And then for us today, and where we're really going to be focusing today, is that a powerful way we can help save lives and really combat stigma is to provide life-saving treatment in medications for opioid use disorder. We all know sort of on the left is just, again, showing us the problem of the opioid epidemic, which I think we're all well aware of. But really importantly on the right is that people with substance use disorder are very unlikely to receive treatment, despite the fact that we do have very evidence-based treatments, particularly for opioid use disorder. So just this tiny portion of folks are receiving treatment, and this is something that we can help with. So our focus of today, of course, is going to be a little bit more about the mechanics of medications for opioid use disorder, which we'll often call MOUD, also sometimes referred to as MAT, medication for addiction treatment. These are, evidence-based, highly evidence-based medications that help address the issues related to that opioid dependence, particularly agonist therapies, which we're going to talk a little bit more about in detail, remedy symptoms of withdrawal, and can really decrease or eliminate cravings and therefore, prevent relapse to any opioids. There are 3 medications currently approved by the FDA to treat opioid use disorder, and those are buprenorphine, which will also oftentimes be called Suboxone, or there's methadone and naltrexone, and naltrexone is the antagonist. And I will talk a little bit more about each of those. So most important take home really is that medication, specifically the agonist medication, so methadone or buprenorphine, is absolutely undeniably the gold standard treatment for opioid use disorder. We see over and over in robust data that these medications decrease the use of opioids and opioid use disorder related symptoms. They reduce the transmission of infectious disease such as hepatitis C and HIV, and are very much more cost effective in terms of avoiding costs of those treatments, avoiding emergency room visits. They do reduce involvement in the criminal legal system. They decrease opioid overdoses, really importantly. And various studies have looked at sort of the different decrease in mortality, and all of them show tremendous decrease. But in particular, in 2023, there was an article that looked at people who had a non-fatal opioid-involved overdose, and then followed them for the next year to see who was initiated on buprenorphine treatment and who was not. And then they looked at the overdose rate in the folks who did receive buprenorphine, and they found a 62% reduction in opioid-involved overdose death among those who were given buprenorphine. But also really importantly, fewer than 1 in 20 of those people received medication for opioid use disorder in that 12-month follow-up period. So large space still to really strengthen care connections, especially after a critical event like an overdose, and really connecting particularly vulnerable and high-risk groups to care. And then relatedly, there was a systematic review in 2021 that looked again at agonist treatment, so methadone and buprenorphine, in folks who were incarcerated or recently released from incarceration, and showed tremendous mortality benefit for folks who were, while they were incarcerated, in terms of decreasing overdose risk, and then in particular, a large mortality benefit in the 2 to 4 weeks after release from the carceral setting, which is a very high risk time for overdose. So important for all populations with OUD, but there are, really tremendous benefits in particular for these really high risk groups. To review a little bit about the pharmacology, and again, some may be very familiar, but for these 3 different medications, we have sort of up at the top is methadone, and this is a full agonist. So same, fentanyl, oxycodone, all of our full agonist medications. So sort of the higher dose you give, the more opioid effect you get at that mu opioid receptor. Buprenorphine is this partial opioid agonist, right? So we get some stimulation early on, and then there is this ceiling effect, particularly on respiratory depression, which makes it really safe to use. And then we have our antagonist treatment, which is naltrexone, which is when we use it, naltrexone for like the ongoing treatment, but also naloxone is an antagonist as well for overdose reversal. So a little bit more about methadone, which has been a long-standing, very effective treatment for opioid use disorder. And pharmacologically is highly effective. A significant limitation for its use in the United States, of course, is that it is only available from opioid treatment programs, right, which are federally regulated facilities, also called methadone clinics colloquially. So again, this is a full opioid agonist. The initial dose is usually around 30 milligrams, and this can be slowly up-titrated over time. There is absolutely the risk of sedation and overdose, particularly as people are getting started. It has a very, very long half-life, so most folks take just one dose each day. And there are multiple drug-drug interactions to be aware of as well, and the potential for QTC prolongation. So highly effective, but also highly regulated, and does have some considerable safety considerations as well. Buprenorphine, again, this is our mu opioid agonist, but partial. And also really important, which we're going to talk about more later when we talk about starting buprenorphine. It has a really high affinity for that opioid receptor. So when it enters the brain, if there is any other full agonists sitting on those mu opioid receptors, it is going to displace those. And then it binds very tightly, so it actually has that protective effect. So once people are on buprenorphine, if they use another full opioid agonist, they're going to have some blockade effect that's going to help keep people safe. There's a long half-life as well. And there are analgesic properties for this as well, and it's emerging more and more as a treatment for chronic pain. I mentioned the ceiling effect, which makes it tremendously safe, and thus we can prescribe it in all kinds of settings in a way that we cannot with methadone. And it's given sublingually, but also increasingly there are long-acting injectable formulations available that are kind of slowly becoming standard of care. And also can be given IV at much lower dose, which Nick can talk about for the emergency room setting as well. Again, the buprenorphine is available kind of as what we call a mono product or a combo product. The mono product is just buprenorphine alone. The combination is buprenorphine and naloxone together. The naloxone does not act if it is taken appropriately sublingually. It's not absorbed. And it was initially added to the medication as a misuse deterrent, idea being if someone were to inject or use intranasally and they would absorb some naloxone and get more of a naloxone effect. And so, most of the time we're using combo products unless someone is having a reaction to that. And again, I think I've referred a lot already to the tremendous mortality benefits, but this is just another study showing the hazard ratio of folks receiving MOUD versus not, or receiving other kinds of treatment. And, we see very low mortality when people are on MOUD. When people are getting other forms of treatment, they do have lower mortality than none, but the MOUD provides the best mortality benefit. Great, and now I'm going to hand it over to Nick, who's going to discuss MOUD initiation, particularly in the emergency department.
Great, thanks, Eliza. It's a really nice introduction and overview. So I think now that we have some of the building blocks for MOUD, I want to move us into the emergency department space so we can talk about how we can start people there and kind of build different programs to encourage people to be on medications. So this is a kind of an overview. There's actually been 3 studies on this now, and they've all been very consistent that if a patient comes to our emergency departments after an opioid overdose, that their risk of death in the next year is 5.5%. And that was been consistent in US, Australia, United States. This is the US-based study, which really just highlights that this is one of the most sick populations of people that we take care of. And I can tell you that when I was in residency in the middle of the 2010s, when the opioid epidemic really took off, we were not treating it that way. These folks are often young and otherwise healthy and would have, 40, 50, 60 years of life in front of them. And they have this very high rate of overdose and death within the next year. And, we would see them and we would treat them, but then the follow-up was really lacking. We didn't offer medications. We didn't get them to a clinic where they could be helped. And so it was just this really big contrast for what we did for those with heart disease or stroke, who also have high rates of complications in the next year. But I felt like we took those disorders really seriously and allocated a lot of resources towards their care. And so now that we know this, I think we're starting to put some more effort into making sure that the care is optimized for these patients. With this graph, see, this is the next 30 days. So the study is a year, but you can see that the 30 days after discharge, after an overdose, just the mortality rate is extremely high. And it's really peaks in the first 48 hours after they leave our department. So it's a really critical point when patients come to see us, which is why we've developed these programs to encourage people to get on treatment. So the emergency department is one of the very low barrier points of entry for people to get on treatment. I think of jails, prisons, primary care facilities, inpatient services, and emergency departments are places where people who aren't currently on treatment can get started because it is such a deadly disease. Getting these programs up and running isn't that much work. It does require someone to be engaged and to really take the lead. But we've helped do this across the state in over 75 different departments. And smaller emergency departments have fewer resources, and that's okay. You really just need a way to identify your patients. You need a standardized protocol. And then you need to reach out to your community to see which resources you can link your patients to. And so in low resource areas, the programs are, less intricate. And in high resource areas, there's a lot more that goes into it because you have more to offer. But in general, you need a screening mechanism, a treatment pathway, and then some type of linkage to care. And so if you can do those three main things, then you can start people on medications and get them going down the right track. And the reason that this is all so important, is we know that this is a deadly disease. It often strikes young people. And if we do intervene in this way, where we start medications in the emergency department, people are twice as likely to still be engaged in their treatment at 30 days. And so you have this huge benefit to treatment, and you really double the amount of people that are going to be engaged in that treatment in 30 days if we start in the emergency department. And this paper came out in 2015. And I can tell you that in 2015, no one was doing this. And so this was just a really, really big research project that really moved the needle and kind of pushed a lot of us towards starting treatment right in the emergency department. So every department has a different workflow because every department is different. But in general, as I'd mentioned, you need to identify patients. You can do this through a standard triage screening protocol. You can, some sites have signage in the emergency department that encourage patients to identify themselves. You can screen through their prescription drug monitoring program to see, who's at risk for opioid use based on their prescriptions. And then once you screen someone and you talk to them about their use, you need to do a withdrawal assessment to make sure that they're actually in withdrawal. And then based on the results of your assessments, you can move towards your standardized protocol, whether you do nursing BPAs or you have pop-ups for your providers, or you just have a standard workflow on the wall. It just needs to be standardized in your emergency department, and then you can move forward with your treatment. And many times it includes integrating your social workers or case managers or peer recovery coaches to make sure that patients are comfortable with their current care and their follow-up care upon discharge. And so, it just usually takes kind of a lead provider to make sure that all these pieces fit into place. But this is the general skeleton of what is done in the emergency department. I think Eliza did a really nice job of talking about stigma. And stigma, it infects providers, nursing staff, and it also infects the patients and their support staff. So I think we really need to work on, trying to meet the patient wherever they are at in their use disorder and be extra friendly, because I often say that this is kind of the reverse Swiss cheese model, and that, for medical errors, you have to have all these things line up for a mistake to happen. And the opposite is kind of true for opioid use disorder. If one bad thing happens along the way, then the whole thing is off, right? Everything needs to line up for it to go well. But if you come in with a judgmental attitude or, pressuring them, then they're going to kind of turn it off and you're not going to have an opportunity. And so to make sure that we get our bedside manner correctly, we really need to work on paying attention to our language and then praising their efforts. Sometimes motivational interviewing can be helpful, but overall working on creating a culture where people are comfortable talking about opioid use disorder and that patients are comfortable talking about it with us. So here it highlights a couple tools that I use frequently. The California Bridge group in California has a nice packet of resources. So on the left is really their simplified version for treatment. And so just broadly, they identify someone in withdrawal. And if they are in withdrawal, then you kind of have to quantify it. And so I usually go to MD-Calc, I bring it up on my phone, and I put them into the clinical opioid withdrawal scale template and get a score. And so if someone is in significant enough withdrawal that they qualify, which is usually 8 to 12 on this scale, then I give them a dose of buprenorphine. Of course, they're consenting and agreeable to this as well. And we'll talk about different dosing strategies in the next couple of slides, but I usually do go with the 8 to 16 milligram initial dose. And then I wait and we see how they do. And typically patients get better. And if they start to improve, I usually give them a total of 16 or 24 milligrams before they go, because there is, this gap. And once they leave, they have to then go to the pharmacy and get the prescription that I'm going to write for them. And so you want to make sure that they have enough of a dose, because if you undertreat, then they're going to have persistent cravings, withdrawal symptoms, and they might very well go back to using the opioids from the street that they've been using. So it can be this simple in a standard case. The big thing that sometimes people get tripped up on is how long to prescribe for. A lot of times people ask if, is 1, 2, or 3 days of a prescription sufficient? And usually not. You do want to try to discharge them with a prescription date and time in hand. We call it a warm handoff, where they know where they're going and at what time. And then you should prescribe for as long as it takes to get to that appointment. So if the appointment's in 2 weeks, then you should do a 2-week prescription. If the appointment's in 3 days, then you can do a 3-day prescription. But sufficient prescription is very important from the emergency department. The one little tree here that I hadn't talked about yet is that if someone doesn't have significant withdrawal, then you should not give them medication, because you can cause them to go into withdrawal. I'll talk about that in a moment as well. And so in those cases, what I usually advocate for is a prescription with what we call a home induction, where you can, start to go to withdrawal at home. And then when you're in severe enough withdrawal, you can take medications to treat that withdrawal and start your treatment. And so there's a variety of different ways to do this, but overall it's pretty simple. Here is a more intricate version of what I just showed you. And so I think, most of the the backbone of this is similar to what I just showed, because this is the San Francisco General Hospital protocol, and that group is where the California Bridge team is largely located, that in Highland. But this is just to show kind of what a full protocol would look like that you could start. And I don't think you need to get too creative, because there are many of these protocols out there and they're all pretty similar. And so if you're looking to start a program, go to resources that already exist, modify them to your group's liking and to the resources available. But in general, it's identifying opioid use disorder and withdrawal, then treatment with a dose that your group agrees upon, and then usually maximizing the dose before discharge, and then making sure that there's an appointment scheduled upon discharge with wraparound services, Narcan prescription, or you should leave with a Narcan if possible, recovery coach follow-up, social work follow-up, to make sure that they actually get the prescriptions and they can follow up in the clinic. A lot of times what prevents people from following up are things like safe housing and transportation. And so addressing some of these social factors is really important to make sure that that's not the thing that blocks our treatment, right? It's really unfortunate when someone comes in looking for treatment, the induction works, they feel better, you get them a prescription, they have the insurance, and then they can't get a ride to clinic, right? If one thing falls apart, or one thing falls through, then the whole thing falls apart. So trying to think about the whole pathway is really important for this disease. I just went through a couple of pathways in which I advocated for either 8 or 16 milligrams of initial dose of buprenorphine. There are some pathways that will advocate for lower dose initiation, because fentanyl is very prominent, right? It's the majority of the street opioid currently. And fentanyl is very lipophilic and can be present in the plasma for a longer than expected period of time. And so in general, if someone using an opioid and they haven't used in 24 to 48 hours, you would expect that their plasma concentration is not very high, and that giving them a dose of buprenorphine would not cause withdrawal. But in fentanyl, because it is continuously released from the fat, you can have elevated plasma levels for longer than you would expect, which theoretically increases the risk for precipitated withdrawal. And so if you start at a lower dose and you take a longer period of time to start the medication, that might reduce the risk of withdrawal. But the reason I continue to advocate for the higher dose initiation in the emergency department is largely pragmatic, in that having a standard protocol makes it easier for us to do it. And I'll say that a lot of emergency physicians are pretty hesitant and nervous about doing it. And so really standardizing it and making it simple is very important for uptake. But the reason that that's okay to do, I think, from a safety perspective, is because there are these large studies going on right now. And in this paper, I think they're comparing long-acting initiation of buprenorphine subcutaneously versus a standard sublingual dose that I described. And among 1,200 patients, only 9 had precipitated withdrawal. So, a pretty low rate of this happening. And so it's not something that I think we should really change our protocol in the emergency department. Now, I think that low dose initiation is certainly appropriate in different settings, surgical wards, outpatient settings, in the hospital. But for us, if we do have some precipitated withdrawal, it's pretty easy for us to manage it. And it's rare that the simplicity of the single large dose is most important. So I'd alluded to precipitated withdrawal a couple of times, but in general, what happens is if you're in a full agonist like fentanyl, methadone, morphine, and the receptor is fully activated by those medications, and then you are given buprenorphine, which has a higher affinity, and it removes those full agonists, you get this relative withdrawal. So you go from full to partial, and you feel very sick. So the key is waiting until that green line crests and then decreases below where the blue line would be. And so if you still have some full agonists like fentanyl on, but you're in withdrawal and you get buprenorphine, you will feel better because you're being lifted up to the partial agonist compared to being brought down on a relative basis. Here's another diagram of that. And so if this were to happen, again, because we're in the emergency department and, can kind of be quickly transitioned into a sedation type situation or critical care, it's very important to aggressively act. And that if someone gets very sick after they start, then you want to, depending on the pathway, give them a large dose of more buprenorphine, which seems counterintuitive, but eventually enough buprenorphine will make them feel better. And you can use adjuncts such as benzodiazepines or antipsychotics such as Haldol or olanzapine or droperidol to help with some of the anxiety. And in general, this is something that's easily managed to someone that kind of knows step 1 and step 2. For more mild withdrawal, like if someone were to have some mild symptoms of withdrawal after starting and they don't really want to continue today, maybe they want to take a day or 2 off and start later, you could give some of these adjuncts that are non-opioids just to treat specific symptoms. I think that's fine. In general, I like to get them on the medication because then once you're on buprenorphine, the risk that you overdose in the next 24 to 48 hours is much lower. And we know that those first days after an ED visit are really dangerous. And so I prefer to get them started if possible. But if not, some of these alternatives can be helpful. I only have a minute or so. So I'll briefly talk about naloxone precipitated withdrawal, and that in general, if someone is an opioid withdrawal, the treatment of choice is buprenorphine. If it's buprenorphine precipitated withdrawal, you should give more buprenorphine. If it's regular withdrawal, you can give buprenorphine. And even if it's naloxone precipitated withdrawal, high doses of buprenorphine can outcompete the naloxone and make them feel much better very quickly. And then the nice thing is now they're on the buprenorphine. And so they should be protected from cravings and overdose while they're on treatment. And hopefully you can get them into a clinic for ongoing care. I previously talked about the low dose initiation and about how this is a good strategy in some settings, but I don't think it's a great strategy in the emergency department because it does require, multiple days of them still being usually on their primary opioid. So if that's street opioids, that's fentanyl, which is dangerous. And it just takes a longer time. Whereas in general, I can get 99% of my patients on the buprenorphine within an hour. And I find that to be preferable. In pregnancy, we used to only use the buprenorphine, not the combination product. But multiple studies have been published now that show that there's no difference. And so we should use the combination product as much as possible. But for the purpose of the emergency department, the reason this is important is because some older pathways had required labs and pregnancy testing, and that's not necessary anymore. You don't need any labs or pregnancy tests to start medications. And it can be used in young people as well as older people, but buprenorphine can be given to those 16 and older, where methadone is 18 or older. Just do remember that buprenorphine, while is safe for adults, does cause significant respiratory depression to children. And so your standard discussion of safe opioid storage should be done for buprenorphine, just like you do for anything else. And when you have this discussion, remind them it's a chronic disease, and that they will, benefit from being on treatment for at least a year, probably 2 years, and lifetime is fine if they're happy with that. And that they should also get they should get peer recovery services, social work, and Narcan to go home with upon discharge. All right, Eliza, back to you.
All right. I think we're ready to go. Thanks, Nick. So it's really, I am a primary care provider and addiction care provider in the outpatient setting. And over time, we see increasing numbers of folks coming to us after initiating in the emergency room, and the efforts are so appreciated. And I think patients are having more and more positive experiences doing that in the emergency room. And then when we can link them to care afterward, it can be a really effective and really positive experience. So we're going to now switch and talk a little bit more about some of these initiation strategies in the outpatient setting, of course, where there are some different factors at play to consider. So thinking, if you're a person who is interested in starting this in your outpatient setting, there are some parts of your system that can really help you do this well and more easily. However, as I go through these, I also want to keep in mind that even if you cannot make these other changes in your clinical setting and you decide that you are going to initiate medication for opioid use disorder, that alone is going to be life-saving. So the additional bells and whistles are really helpful and wonderful, but even if you don't have them, please don't be discouraged and think that you cannot begin prescribing. So things that can be helpful sort of from a staff standpoint, of course, is staff buy-in training, right? People understanding why this is so important, understanding the stigma of addiction. Some cross coverage from other providers, of course, so that if you're a prescriber, you can occasionally be sick or go on vacation. If possible, it's great to co-locate other services and other multidisciplinary staff, medical care, behavioral health care. Within the clinical system, having workflows for things like drug testing, troubleshooting prescription problems, et cetera, can be very helpful. And, just again, having other types of resources available in that same setting so folks can get different kinds of, one-stop shopping to meet some of their other needs. In the community, really helpful, of course, if there is an available higher level of substance use disorder care. So that, if a patient is struggling with outpatient treatment and MOUD, there are other places to refer them. But arguably, of course, if you're in a place that doesn't have higher level of care, this care may be even more important, right? Because people don't have other options. So kind of now thinking about what this visit with a patient is going to be like. We're going to sort of walk through some different steps, but just, generally thinking about how we take this history. And this really goes for all of the medical care we provide now at this point, right? But I think especially important for patients who have walked through the world feeling shame and stigma everywhere they go, and particularly in the healthcare setting, and will feel extra nervous and reluctant to share. So ensuring as much physical comfort as can be possible, asking questions, but asking permission first to ask those questions, especially when they're more personal questions. Letting folks know why you're asking those questions, right? Especially some of the detailed questions that feel so normal in our medical interactions actually feel really jarring and probing for patients, and they don't understand why we need to know things like their sexual history, for example. So explaining that, using as much clear language as we can, person-first language, and also as we're typing in the computer, sharing with the patient what we're documenting. And so that people understand where that information might be going, especially for carcerally involved folks. This can be really important, right? Who are going to have extra difficulty trusting that information remains private sort of within the healthcare space. And then, of course, if patients are, either feeling reluctant to share, not, pressing them for information in that very first visit. So first visit, key pieces to try to cover. And as I walk through this, I just want to emphasize that it's, ideally, if we have the time, it's great to gather all of this information at the first visit. However, I'm a primary care provider. We do these visits in 20 minutes, and that is possible as well. We don't have to get all of the information at that very first visit. And this little cartoon is just alluding to, I think, as we all experience now when we go to the doctor's office, right, there are just increasing numbers of forms to complete. And it can be overwhelming for patients. And so by the time they get back to the exam room, they already, may be feeling overwhelmed by information that's been asked of them. So it's okay to tailor this and not get all of the information at the first visit. But key that we do want to get at that first visit is at least a diagnosis of opioid use disorder. And we've talked about that a little bit. Generally helpful to know a little bit more about just sort of their total exposure to opioids, right? So when did they start using? What were those circumstances? How long did they use? What types of opioids? And then especially route of use, which is going to help us think about not only tolerance level, but also risk of infectious disease and other complications. Asking about overdose history. And again, this is like helping us risk stratify a little and possibly provide some education for the patient in that moment. Learning about what medications they may have tried and really like what happened. Were they on methadone and it was really effective? Why did they stop it? Were they on buprenorphine and they discontinued it? Like what wasn't working? So those can be really helpful parts of the conversation. And then learning the last time of opioid use. And again, this is going to feed into how we're going to do our initiation strategy. Learning about other substance use. So this can be done in a very detailed fashion, but it does not have to be in order to initiate buprenorphine. So my personal practice, again, when I'm in a rush, is just generally learning kind of what other substances are a part of the picture right now. And most people are using polysubstances, right? Whether they are intending to or not, because of the contamination of the drug supply. But just learning a little bit more about what are really active substances for them now. Again, what are the routes? I do specifically ask about sedatives. So, high doses of gabapentin, large amounts of alcohol, large amounts of benzodiazepines, just because those are the other substances that will have a direct potential dangerous interaction with buprenorphine. Not a reason that we need to withhold buprenorphine, but a point of discussion and education for the patient. Over time, I do try to learn more about sort of, consequences of their other substance use, their goals around their other substance use, safer use practices, and just always remembering to ask explicitly about alcohol and nicotine and marijuana, actually, because those are ones that folks at this point usually won't share when you ask about substance use. So other really important pieces. But again, a lot of this can be done over time and doesn't have to be at the first visit. Learning about mental health diagnoses. So, and again, this can be done more over time. But learning about people's prior diagnoses and which does the patient feel are relevant or accurate. Do they think those diagnoses were made while they were using substances or in withdrawal? Right, we see a lot of overdiagnosis of things like bipolar disorder. That with detailed history, it turns out that was a diagnosis given while someone was using methamphetamine, for example. What have they tried before? Counseling, medications, etc. What do they feel like they want to do regarding treatment now? This is just really, it doesn't change what we do with our buprenorphine specifically, right? But as we think more holistically about how are we going to help this person stabilize, control of mental health conditions is going to be important. And of course, there's a very high prevalence of mental health conditions within folks with substance use disorder, like well over 50%. Social history, this is once again, do not need every detail at the first visit, but these are going to be really important for someone's longer term recovery. So housing, social supports, people as they stop using substances, one of the key challenges is that a lot of their prior social supports and social connections all revolved around substance use. So helping folks find those new social connections and networks is really important over time. Learning about folks' legal involvement, particularly, are they on probation or parole? That's going to influence how they show up to clinic, the stressors they're facing, the financial limitations they're facing. And this is just a little plug on the side for this Curbsiders podcast, which I can't recommend highly enough, and talks a lot about, sensitive ways to ask about criminal legal history. And then if possible, finding out about employment, finances, education, etc. And again, can be done over time. This is something that I feel is important to try to ask about at the first visit, but again, learn over time, which is really finding out what the patient's goals are. I think a lot of times, of course, in medicine, we have our specific goals that we have for a patient, but that may or may not really align with what their goals are. And so we need to learn those and align our care with that. These are just quotes of things people have told me over time. And, oftentimes people will say their goal is like, stop using substances, but really trying to learn sort of what is underneath of that goal is going to help us engage and motivate them over time. Also recognizing and, voicing to the patient that abstinence does not have to be their goal. Maybe it's just using more safely. Instead of using every day, they want to only use on the weekend, and they only want to use when they're with someone there to keep them safe. So those are some things to explore again over time, and having that conversation conveys to the patient that you understand that there are different ways of recovering, there are different goals that people might have, and so it can really be an alliance building conversation. And then general health, again, things that they may not be ready to address immediately and usually aren't, right? They want to sort of stabilize on the medication, understandably, feel better, not be in withdrawal, not be craving, but over time, making sure they are connected to a primary care provider, or awesome if you are a primary care provider and can offer that care. Do they have any acute conditions that need to be dealt with? Again, what medications are they on? Are they up to date on their infectious disease screening? Excuse me. And these are often things that I find people are not ready to talk about and think about on the first visit, but a couple months in, they're starting to feel better. They do want to start addressing a lot of these issues. And then checking, based on what your clinical setting decides about toxicology testing, and there is no robust evidence of exactly how this should be done, how frequently. So a lot of debate around that, but whatever is decided in your clinical setting, just being sure to communicate really clearly with patients about how that's going to be used. Of course, folks who especially have had carceral involvement, but anybody has often had a lot of trauma and fear around like what happens with their urine results, right? People have been discharged for care. People get sent back to jail or prison. They get their kids taken away from them. So really being explicit about how you as the clinician plan to use those results and how often they'll be asked to leave those samples. And then when you are, when you get the results, like being sure to include the patient. And I'm finding in my own practice, increasingly, it can be an educational tool for patients because of the contaminated drug supply. People may think they're just using cocaine, but there are 4 different things in that cocaine. So that can be helpful, and again, helps you align with the patient if you review those results together and try to make sense of them together. And then definitely always reviewing the PDMP, or MAPS as it is here in Michigan. So before you've kind of done that history, you want to make sure you do your informed consent and shared decision making. Some clinics will have a whole thing to sign, and some you can just have the conversation. There's no requirement around that. But things to really cover are, of course, making sure folks understand that there are 3 FDA-approved medication options, and the risks and benefits of each of those. Sharing a little bit more about buprenorphine pharmacology. And I find in my own practice, it's very common. Folks will come to me on buprenorphine and have no idea really what it is or how it's working in their body. And it is important for people to know that they will be dependent on this, right? They won't be addicted to it, but they will have physiologic dependence. And so, abruptly stopping is going to make them feel sick. So important that people know that. Reviewing the opioid start talking form if you are in Michigan. And then, some recommended labs, but these are absolutely not required prior to initiation. And, in my own practice, I think about 5% of patients actually do this before we initiate. Again, right, folks are not usually ready for phlebotomy when they're, in active withdrawal and trying to stabilize. So these mirror a little bit what Nick has already talked about. So we have similar options, but again, the dynamics can be, and the counseling can be a little bit different in the outpatient setting. And I will say, these are 3 strategies, but there are about 400 ways being experimented with right now for how to get folks initiated, including, promising data from using long-acting injectables. But these are just sort of the 3 at this point that we're using more in the outpatient setting. Again, as Nick mentioned, right, this buprenorphine used to be kind of in the olden days of heroin. It was pretty straightforward how to initiate. People needed to wait about 12 to 14 hours before they could get started. But fentanyl has made that much more complicated. So people have really been asking for other ways to do this. So in the clinic, we can certainly do that sort of standard initiation, right, where we have the person stop, go through withdrawal, free up some of those receptors. Unfortunately, with fentanyl, that takes, more on the order of 3 or 4 days rather than just a half a day or a day. So we can absolutely support folks with those withdrawal medications that were discussed previously. And, I think about this again, outpatient setting is a good place to do it. If somebody comes in already in withdrawal, that's a great time, right? If they have already waited 2 days, then they're getting pretty close. Or if a patient says, absolutely, I'm done using today, I never want to do it again, this is something to consider. And these are the withdrawal support medications. And then there's the low dose initiation, which Nick talked about. And again, maybe less fitting in the ER setting. We are using it more in the outpatient setting. And you can see there are a million different protocols out there, but, overall idea is we're just introducing very tiny amounts of buprenorphine increasingly day by day by day. And I sort of describe this to patients as sort of like we're sneaking buprenorphine into your brain so that it doesn't notice, right? We're just doing it very, very, very slowly. The really important part of this and the counseling piece is that the patient has to continue using a full opioid agonist during this process in order for it to be successful. So for some patients, that doesn't sound good at all, right? They use their last fentanyl, they're done, they never want to see their dealer again. This isn't going to be successful. For other people, they actually, aren't quite ready to totally stop using yet, and they have a supply at home and they feel like it is as safe as can be possible. So this might be more fitting for them. And the idea is that this would avoid any withdrawal symptoms at all if it's done the right way. Also really helpful when people have comorbid chronic pain so that they don't ever have to go through that withdrawal experience, which worsens pain, obviously. And then high dose initiation, this, very similar. Nick already talked about it for the emergency room setting and definitely being used more in the ED and I think is better suited for the ED, but it is also an option in the outpatient setting as well. And just when you're writing your first buprenorphine prescription, the duration depends on a whole number of things, kind of how you're doing your initiation, various financial constraints your patient may have. Are they paying out of pocket? Do they have access to the pharmacy? When can you next see them in clinic? And really important to make sure that they aren't running out prior to coming back to see you in clinic. If at all possible, some check-in or phone call as they get started is really helpful. And then always prescribing naloxone as well and reminding patients about potentially those interactions, especially with sedatives. And Nick talked also a bit about dosing, but again, we're seeing in the setting of fentanyl that people need higher dosing than what was initially recommended by the FDA. And the package insert hasn't been updated to reflect the changes in the drug supply. So most folks, if they are using street fentanyl, are going to need more than 16 milligrams total daily dose to start. And we do see that higher initiation dose, 24 milligrams, 32 milligrams, is associated with a decreased return to opioid use and better retention and treatment. Most people do like their buprenorphine divided up, kind of BID or TID. It's also fine if they want to take it once daily, but most folks prefer to divide it up. And then addressing precipitated withdrawal, similar principles, but in the outpatient setting, it is, of course, harder because people are at home typically or wherever they reside. And so this is really kind of a counseling discussion with a patient and shared decision making. Again, the thing that's going to make them feel best is taking a large dose of buprenorphine, as Nick already stated, but that can be really scary for people to do and to do that at home. So other options are kind of like taking small bits until symptoms improve or just kind of stopping the initiation, waiting until more of those receptors are free and starting again. All right, and moving on to Nick to talk about acute pain management.
Great, thanks again. Okay, so in the emergency department and in the hospital, I really think it's so important that even if you have no intention of starting someone on buprenorphine, that you at least know how to manage acute pain, because this is really severe disease that they have. It's chronic, and these medications can make it really hard for them to get adequate analgesia if something painful happens to them. And so the last thing you want is for someone to do well in their recovery where they're on medications, and then something bad happens, like a car accident or even a kidney stone. They feel miserable because of it. No one's treating their pain. And they decide, that's it. I'm not doing this anymore because in the hospital, I was made to suffer the whole time. And so knowing how to manage pain is really important. How to do it requires some understanding of the basic pharmacology. And so as Eliza mentioned, buprenorphine has a really high affinity for the mu receptor. It binds very tightly. It's like naloxone in a sense. In that way, it's just going to displace other medications. It only partially activates it. So it does offer some pain relief, but it is not to the level of a full agonist. Whereas methadone is very loosely bound to the receptor, but does fully agonize it. And naltrexone has a very high affinity, but a full antagonist. So completely blocks it and does so in a strong way. So by understanding the ways that these medications work, we can then do some workarounds. Oh, I do want to mention, I guess, this graphic that it does highlight that this is kind of a change in the past 7 years or so, but it used to be that people would stop people's buprenorphine for hospitalizations or procedures. And now standard practice is that buprenorphine should be continued even when we know that, a painful procedure is upcoming, because it makes the whole thing a lot less complicated. If you stop someone's buprenorphine, then restarting them is a challenge, and their pain control isn't optimized. And so it's best to continue it. Okay. So for buprenorphine, and I guess in all acutely painful situations, the best thing to do is to try non-opioids first, right? We know the mu receptor is occupied. And if we can try strong NSAIDs or Tylenol, nerve blocks, mobilization, ice, that's great. And then in the right setting, I often go for ketamine first, because it's not active so much on the mu receptor. And so it's kind of a workaround where it still provides analgesia, but isn't blockaded by buprenorphine or naltrexone. The other option is that if the other ketamine is not working, nerve block isn't an option, that you can do higher doses of opioids. And so, I think a lot of times we get into habits of which doses we order of things like fentanyl or hydromorphone for someone. And in reality, we should be titrating to effect rather than a specific dose. And so these patients are going to require higher doses because at the receptor level, the fentanyl, the hydromorphone is competing with the buprenorphine. And the buprenorphine does bind more strongly to the receptor than these drugs do. But if you give enough of them, it'll have some effect. And again, I have a luxury being in the emergency department where someone is closely monitored. We can kind of move to a sedation type situation if needed, but I don't think someone should be suffering because, we think that a smaller dose of fentanyl is what we usually give. These patients are going to require higher doses to make sure that their pain is well controlled. The other trick is that for more minor painful conditions, like if someone's having a kidney stone, NSAIDs are working okay, but you need to make some modifications, I often just have them change how they take their buprenorphine. So you can, if they're on 16 milligrams a day, go up to 24 for 5 days. Or if they don't want to increase their dose and they're taking it once a day, if you split dosing, that increases the plasma concentration of the drug because it's peaks over 6 hours and then it really kind of equalizes. And so if you do split dosing, you're going to have kind of more peaks throughout the day that are going to help with pain control. So there are some tricks with the home medication that you can do, but otherwise use your non-opioid medications when possible, and then high-dose opioids if absolutely needed. This is the study that shows this peak plasma concentration based on initial dose. And, the extent varies based on the dose, but the pattern is the same, that there's a peak over 6 hours and then it equalizes. And so if you do more frequent dosing, you will have a higher plasma concentration average throughout the day. And then how much they're on does impact what you do as well. So the second graph shows that at very low doses, only a small percentage of the opioid receptors are occupied by buprenorphine. So if someone's on, they're just starting a low dose titration and they're on 1 milligram, well, you can use your normal opioids without, significant problems. But if they're on 32 milligrams a day, most of those receptors are going to be occupied and you're going to have a harder time controlling their pain with opioids. Moving to methadone, remember this is the low affinity, long-acting medication that's a full agonist. It does take quite a long time for them to get to a steady state. They have a slow up titration in their dose, but because it's so long-acting, it does, you don't usually go through withdrawal after missing a dose or even 2 doses of methadone. Patients will feel very anxious about doing so, but physiologically, you should not go through a significant withdrawal with a single missed dose. A lot of times if someone is feeling pain or some withdrawal after missing a dose or having something acute happen to them, you could give them 20 or 30 milligrams of methadone without too much concern that you're going to cause too much respiratory depression with that extra dose or substitution dose. And then you can use other opioids. So just be careful, right? You want to be in a monitored setting, but you can give opioids, and like a fentanyl, for example, or hydromorphone would outcompete methadone, and it wouldn't be blocked. So you can use opioids freely, but you just have to be careful because you're going to have a higher rate of respiratory depression. And then naltrexone is really tricky, right? Because this is often in injectable form. So they have essentially a 30-day depot of opioid blockade in their subcutaneous tissue, and it has a high affinity. And so this is another one where you want to use non-opioid options to the best of your ability. And then if that doesn't work, you're going to have to use opioids to effect. And so don't get intimidated if you have to do 100, 200 of fentanyl every 30 minutes. Most of the medication is not getting to the mu receptor. And so they won't have significant respiratory depression like you typically would expect at those doses because only a component of it is being active. So as with everything related to addiction treatment, I think shared decision-making is just really important. Trying to understand what their goals are and where they're at in their stage of disease. And so that we can optimize their experience and to make sure that they continue on their treatment, because continuing on their treatment is just so important for their well-being long-term. But a lot of times, the most important thing for them is that their pain is managed. And so we have to do that. And then sometimes you have situations where they want their pain managed to the best of our ability without using opioids because they don't want the stigma of, using fentanyl again, even if it's medical or it's just like a personal goal for them. But just to decide together what's best for them and work from there. Okay, that's the end of my presentation. And so now we can open it up to questions.
Thank you, Nick and Eliza, for that excellent overview of this incredibly broad and complicated topic. I am going to take a peek and see if we have any questions. So there is one question so far, and this would be for both of you. Do you have universal screening for OUD in your emergency department? So that would be for Nick. And do you have universal screening in your clinic? So that would be for Eliza. If no, why would that be? If yes, how did you implement this? Nick, I'm going to ask you to answer first.
Sure. We do not. And the reason is just more technical. I'm at Trinity Grand Rapids, and the computer system, we have the Epic system. It is uniform for screening purposes in all 100 emergency departments that Trinity has. And so it would be, it's not customizable. And so we didn't do it. In sites where it's more customizable, I think it is possible, but it's also important to understand that there is a lot that goes into emergency department screening already, right? We're screening for travel and domestic violence and food insecurity, and it's all worthwhile, but you can't screen for everything. And then the next question is kind of, what do you do with that information if someone screens positive? And so it's very resource dependent. If you don't have someone to do anything with the response, then it kind of gets collated into the chart and no one does anything. And so it's really site specific and it can sometimes be challenging, but a good idea if you can do it.
Yeah, and I can just tag in, actually very similar to Nick. We don't have a universal screening in our clinic. Apart from, we have like the general form where people like fill out, it's like, 4 pages of their social history. And so there are questions about substance use. We don't have like an evidence-based screening tool that we're using. Reason being are fairly similar, sort of like, again, the number of questions people already get asked, and then can those be dealt with in a short period of time? And then, right, the feeling of a patient, if they check yes to something like that, and then no one notices or no one follows up, feels detrimental. That being said, we do absolutely do a lot of education with our providers and, we have a large addiction team within our primary care setting. And so people are pretty aware of our existence. So I think they are oftentimes a little more likely to ask for it in their visits because they know there's like a good resource that they can send patients to. So a lot of like clinician education about how to have that conversation. Also, I think there is always the risk of those screening tools, right? People feel uncomfortable checking boxes about things, especially about stigmatized topics. So I think sometimes the screening tools can be sort of a false security blanket of thinking that we've done all we need to do. And sometimes like asking about it over time as a clinician can actually be a more effective way to do that.
Thank you. In our ED, there are a half dozen screening questions that the triage nurse has to ask. And so we do not have universal screening, but we do have posters in our waiting room and in our exam rooms inviting people to talk to any of their providers about concerns related to substance use disorders. And so that's how we kind of figured out how to invite people to self-disclose and share with us if they want help, and to just make sure that people are aware that this is something that we offer in our ED. One question that came up was concern about diversion. So Nick, you mentioned that you give 3 days up to 2 weeks of buprenorphine. Is diversion a concern for you or not so much?
Say diversion is not a concern that I have. Most diverted buprenorphine is sold and used due to undertreatment of the disease. And so these are folks that want treatment, but either don't know how to get it, or their insurance doesn't cover it, or there's some other complication. And so it's not diverted, I feel like, in a dangerous way. Of course, we don't want any medications diverted, but I don't feel like I'm doing societal harm if a diversion were to occur. And so on balance, when I think about the benefit of the medication versus the risk of the ongoing disease, I certainly err in prescribing longer rather than more briefly.
Right. There is a question from our audience regarding an allergy to cocaine. So it sounds like they had a patient who received cocaine for a sinus operation. So for those of you who are clinical, we will sometimes use cocaine to achieve hemostasis, so to stop bleeding. So someone who has a terrible nosebleed, many times I've literally soaked a cotton ball with cocaine and put it in their nose. So I'm guessing this is someone who did something similar, and they had a patient have an allergic reaction, and they're wondering how likely is it that they'll be allergic to other medications or substances. Do you guys have any idea about like cocaine allergy as like an entity?
I don't specifically. I would imagine it's not any different than allergy to anything else in terms of raising risk for other allergies, if that's the question. But I don't know for sure.
Yeah, I agree. I think the chemical structure of cocaine would dictate whether or not someone has a cross-reactivity with another medication, but I'm not aware of any like obvious associations with other medications that we prescribe routinely or other substances. One more question. I work in a clinic without a lot of social supports. I don't have a social worker who's routinely available. Can I still provide MOUD? And do you have suggestions about how to do this? This would be a question for Eliza.
Yeah, I'm so glad you asked it. And 100% yes, you can. And I'm glad you're thinking about it. So again, all of those other supports are very much helpful, but you can do this just prescribing a medication just like you would any other medication. I would say kind of in terms of other supports that you really do ideally would have, number one would be just at least one other provider who is also a prescriber, right? So you have some element of cross coverage. That's probably the number one thing that you need. But even if you don't have a social worker or you don't have community health workers or any other resources, you absolutely can do it, just prescribing, just as you would their medication for hypertension and everything else. So yes. And if you ever have additional questions about that in more detail, I am always happy to. I don't know if our emails are here, but or will be shared, but I'm always happy to have a more detailed conversation about that as well.
Yeah, and there's a wonderful at the elbow support that multiple providers at Michigan and I believe also at Trinity participate in through Open and the Michigan Opioid Collaborative. So if you are working in a clinic and you're thinking about how do I operationalize this, but you have questions or you just want support the first time you do it, you can call in and they're available during the day and they'll just literally walk you through everything. I know the first time I do a new procedure or I see something that I haven't seen before, I really like consulting with somebody, whether it's just a colleague that I pull over and do a quick conversation or calling, an expert consultant. It's always super helpful. And so that is also available to you. And we'll make sure that that information is part of the resources that we share for anybody who is requesting the slide deck. Let's see. One last question. Do you see higher rates of opioid overdose mortality in individuals who use by themselves versus individuals who use in groups or with another person around? I think either Nick or Eliza could answer that question.
I don't particularly know numbers. You might, Nick. I do know certainly that it is a very well-established harm reduction technique to use with others, but I haven't actually seen any data of anyone comparing the difference between the two. I don't know if you have, Nick.
I think using in groups is far safer, especially it seems anecdotally that people that want Narcan have that now. And so we're seeing people who come in post-overdose who got Narcan from their friend. This didn't happen when it was starting in 2014, 2015, 2016, right? Those people just died. And now they're using it in groups and they're saving each other. And then they come in, they're okay. So I think that's been a big change over the past 7 to 10 years.
Yep, I think, and it's a great, there are a number of harm reduction strategies that you as a clinician can talk about with patients that are pretty easy. And not using alone is a huge one of those, along with kind of like, using a small test dose first. Also, people are using in a group, not all using at one time, right? Using in a staggered fashion. And those are, great tips to share with patients.
Yeah, I think it also kind of gives power to our patients and to the lay public that they have the ability to reverse an overdose and save somebody's life. So in my emergency department and in many emergency departments across the state, we have naloxone kits that we can give out. And this is an effort through Medic and Open. And so I often have people say, well, I don't need the kit, or it doesn't apply to me, or I already have a dose of naloxone if I need it. And I always remind them, first of all, you might use your naloxone. Second of all, you can give this kit to somebody else. And third of all, this empowers you to have some level of control and to potentially help somebody else. I think the other thing that's important to tell people, because not everybody has, acquaintances who might be comfortable with them using in front of them, is that there are some apps, including the Brave app, that patients can load onto their phone, and literally they activate the app and the app detects their breathing. And so if they were to slow down their breathing, it basically stimulates them. It vibrates, it makes noise. And the hope is that the patient would wake up enough, take a few good deep breaths, and not have, a respiratory arrest as a consequence of their use. So there are a lot of really good harm reduction strategies out there now. MDHHS supports a really wonderful harm reduction summit every summer, where if you're not as familiar with these strategies, you can go and learn more from folks who are way more expert than me. We also had a really nice discussion around harm reduction a few months ago. We have those slides, we have that presentation. If anybody missed it and wants to, gain access to that, we're happy to share it as well. We are at time. Thank you, everybody, so much for your attention. Thank you for your great questions. With that, I'm going to close our discussion. Thank you again to Eliza and to Nick for sharing your knowledge with us today. On behalf of MDHHS, on behalf of my colleagues at the University of Michigan Injury Prevention Center, I hope that everybody gets to enjoy a little bit of sunshine after all those storms we had over the weekend. I hope you have power, and I wish you well. Take care. Bye-bye.
Thank you.